Yeah, we are live on YouTube now. Everyone have got the message that the program is live. So, and we are live on YouTube now. Everyone have got the message that the program is live.
Mr. Pratik, whose video is being showed right now?
Sir, right now your videos is shown, sir.
My video?
Yeah.
Okay.
विक्रम बाजूला YouTube लावून ठेव तुझ्या याच्यावर फोनवर, म्हणजे तुला ते कळेल काय दिसतंय तिथे ते.
सर
थोडा एक 20 सेकंड लॅग असतो, 20-30 सेकंडचा लॅग येतो. आपल्या IMA चॅनल वरच असेल ना YouTube वर?
Yes, sir.
I think we will start in 1 minute.
1 minute.
Right?
सुरू झालं. थोडासा लॅग आहे फक्त, बरोबर आहे.
20 सेकंदाचा लॅग येतो.
हो सर, हो सर, बरोबर येतं सर क्लिअर तरी. 4 people are watching right now. I think 3 are here only. I'll turn off my video for some time. Yes, sir.
We can start, Vikram. Ashish, right. Sabu sir yayiche आहेत अजून.
Okay, I think we'll start. Respected IMA Vice President Dr. of Maharashtra State, Dr. Dinesh Thakre sir, IMA Amravati President Dr. Rohankar sir, IMA Amravati Secretary Dr. Ashish Sabu sir, executive members of IMA Amravati, all delegates, good afternoon to all of you. On behalf of IMA Amravati, I welcome you all to this web conference, which is a part of AGNIPANKH 2020 IMA Amravati's annual celebration. I'm glad to announce that MMC has granted credit points to this CME. We have 7 to 8 speakers today and tomorrow from various broad specialties, and I'm sure that this web conference will be an academic feast for the delegates. I would like to announce that to be eligible for credit points, all speakers and delegates have to fill the Google form for registration. You can find the link to fill this form on the YouTube page of this webinar. I now request IMA Amravati President Dr. Anil Rohankar sir to officially inaugurate the CME.
Good afternoon. Good afternoon, everyone. We have been deciding about the annual day since last 8 months, whether we can hold it or not. होते नाही होत असं continuous सुरू होतं. But Vikram had taken lots of effort. Ashish and all the executive team helped him a lot. And at last we could materialize the annual event. The sports activities, they are going on. Cricket is going on. And to add academic feast in the entertainment section, we had added this credit point CME to help our members to collect credit points which are needed for the renewal of the registration. We are holding this CME for 2 days, today and tomorrow. And with these words, I congratulate Vikram Deshmukh for holding such a nice clinical feast. And I declare that the CME is open now. Thank you,
Thank you,
Vikram.
sir. Thank you, sir. I now request MOC Dr. Vikram Wankhede to introduce our first speaker, Dr. Praveen Yavare, sir.
Thank you, Dr. Vikram Deshmukh, sir. As you rightly mentioned, this will be an academic feast for today, and we are going to start a 2-day annual day CME program with a very well-known and renowned speaker, Dr. Praveen Yavare, sir. He is a well-known ophthalmologist practicing in Amravati since last 21 years, and he was a pioneer of phacoemulsification surgeries in Vidarbha region, has done more than 500 corneal transplant procedures, and also he is also doing corneal lamellar procedures. He is also director of Vyavhari Netralaya Eye Bank and also associated with several other eye banks. He was a past president of Amravati District Ophthalmology Society, past vice president of Vidarbha Ophthalmology Society, ex-member of Maharashtra Ophthalmology, executive member of Maharashtra Ophthalmology Society. Sir has various publications in his name, was involved in various research activities and as well as presentations in a national and state and national conferences also. So without any further delay, I welcome our first speaker, Dr. Praveen Yavare, sir, on his topic, how to get rid of your glasses. Dr. Yavare, sir, over to you, sir.
Thank you, Vikram, for the kind words, and thank you for second Vikram for giving the opportunity, and congratulations for the beautiful webinar. And I'm going to share my screen now. Okay, just tell me if the screen is visible or not. So my host has disabled participant screen sharing. I think the host need to change the setting.
Yes, sir. You can share your screen now, sir.
Okay. Yeah. Okay. Is it visible?
Yes, sir. Your screen is visible, sir.
Okay. Okay. Thank you, Vikram, again, and thank you, Team AGNIPANKH, for giving me the opportunity. Today, I'm going to speak on throw away your glasses. So essentially, it is a refractive surgery update. Okay. And before going into the details of refractive surgery as such, let's understand the optics of the eye. Basically, our eye has two main refractive surfaces. That is, one is cornea and another is lens. And these two refractive surfaces focuses the light on the retina so that patient or person can see the image or object clearly. So because of the change in the refractive power of the eye, one can have a refractive error like myopia, hypermetropia, astigmatism, and presbyopia. So this is a basically basic conditions which we need to understand before going into the details of refractive surgery. Myopia is the one in which the power of eye is more. So the focus is in front of the retina and the person needs to wear a minus lenses. In hypermetropia, the power is less. So the focus is in front of the retina and person needs to wear a plus lenses. And when the power of cornea in different meridian is different, that condition is called as astigmatism. And we need to correct this condition with the help of cylindrical lens. Now, our natural crystalline lens can focus and can increase or decrease power, and one can see the object clearly from distance as well as near object. So this focusing power gets lost with the increasing age, and that is what we call as a presbyopia. So when we talk about the refractive error or correcting refractive error, we can correct the refraction at two surfaces, either at cornea or other lens. So these are either a cornea-based procedure or a lens-based procedure. A cornea-based procedure like a radial keratotomy, PRK, LASIK, and astigmatic keratotomy, these are more popular procedures. There are n number of procedures which are available, but these are more popular procedure. And lens-based procedures are, we can replace the crystalline lens with the help of intraocular lens and can correct the refractive error. Or you can put the phakic lens over our natural lens, that is called as phakic IOL. Now the era of refractive surgery has begun with the most popular surgery like a radial keratotomy. In RK surgery, a surgeon used to take a relaxing or weakening incision in peripheral portion of the cornea, which used to steepen that portion, and the central cornea used to get flat. So the power would have decreased and it would correct a myopia. So the RK is the procedure which corrects the myopia. But with the time, and because the results are inconsistent, it is a manual procedure, and there are a lot of problems like glare, weakening, which is associated with this procedure. This is no longer done by ophthalmologists today. And we are now using a laser to reshape the cornea, and that is the most popular procedure. Now, when you reshape the surface by putting a laser on the surface of eye, that is called as PRK, and when you put this laser in the stroma of the cornea, that is called as LASIK. In PRK, on the surface, there is an epithelial layer. We need to remove the epithelial layer first to do a PRK, and because if you remove the epithelium, it takes time to regenerate the epithelium. There are the problems associated with this regeneration, and there may be issues of delayed wound healing, and the wow factor is missing with the PRK technique. That's why the LASIK has become a more popular procedure. The long form of LASIK is a laser assisted in situ keratomydosis. So that is basically we are using a laser to change the power of the cornea by changing its curvature, by applying it in the stroma. It ablates the tissue. So basically, essentially, it involves using a microkeratotome or a laser to creating a corneal flap of around 90 to 100 micron, and then you are everting this flap and applying the laser in the stroma, and then after applying the laser, you are depositing the flap. So this is a small video. It has its audio itself. Just tell me whether audio is...
We see through the process of light being transmitted through the eye to the retina, which converts light into electrical impulses that are sent to the brain. The cornea refracts or bends light onto the retina. If the curve of the cornea is too flat, too steep, or irregular, light is refracted imperfectly onto the retina, which affects vision. LASIK is a surgical procedure to reshape the cornea and improve eyesight by correcting so-called refractive errors. For nearsighted people, the cornea is too steep and is flattened. For farsighted people, the cornea is made steeper, and an irregular cornea is smoothed out for those with astigmatism. You're awake during the procedure, and your eyes are anesthetized with special numbing drops. Your eye is positioned under the laser, and a device is applied to keep the lids open. A map is made of your cornea to highlight the areas to be corrected. The surgeon then creates a thin circular flap of corneal tissue using an instrument called a microkeratome or a laser. The flap is folded back, and a different laser is used to remove tiny bits of corneal tissue to reshape it based on the map. The flap is then laid back over the reshaped corneal tissue.
So essentially, the LASIK is basically we are changing the curvature with the help of laser, and we are applying the laser intrastromally. And we can do the LASIK when the myopia is stable, and in case of hypermetropia and astigmatism too. One has to see that the patient has achieved the maturity and completed 18 years of age, and it can correct the myopia up to 8 diopter, hypermetropia up to 5 diopter, and astigmatism up to 6 diopters. But LASIK is not suitable for each and every patient. What we are doing in LASIK here, we are ablating or taking out the corneal tissue. So the cornea is becoming thin. So if the patient has a very thin cornea before and only, and if you apply the laser, the cornea gets more thinner, and there is a danger of ectasia or changing the shape of the cornea. So that's why we need to have sufficient amount of corneal thickness to do this procedure. If your cornea is abnormal, the curvature is not proper, then also the LASIK is not indicated. If there is a tendency of keloid, a patient having uncontrolled diabetic or local problems like a dry eye, meibomitis, and there are a lot of issues if they are inside the eye, these are the patients one should avoid the LASIK. And there are, of course, some complications which are associated with it. But with the advent of surgery and advance of the machines and equipments, the complications rate has gone down drastically. In the LASIK, there are now all laser LASIK is also available. At our place in Amaravati, we use a microkeratochrome to make a flap, but now a femto LASIK is also available to create a flap. And a customized LASIK is the LASIK in which we remove the higher order aberration along with the lower order aberration. Basically, sphere and cylinder, what we remove with the regular LASIK, is called as a lower order aberration. There are a lot of higher order aberrations which we can have, and that can be also corrected. That is called as a customized LASIK. Now we have a LASIK Vision Center in Amaravati since almost 10 years, and there are 7 partners, and we are doing a very good work here. And our OT is usually on the Wednesday. Now there are other procedures like a flex and smile, where the laser is used to assist the lenticular extraction. The small incision lenticule is made with the help of laser, and that we can extract to correct or to change the shape of the cornea and correct the refractive error. Now, if the myopia is more than 8 diopter, then you cannot correct it with the help of LASIK, because LASIK will change the curvature and thin the cornea. Now, if the power is more than 8 diopter, it will sufficiently thin out the cornea and can cause the ectasia issues or a curvatural problems. So the LASIK is not indicated in those patients who have a very high myopia or when the cornea is thin. So for these patients, we do a phakic IOL surgery in which we put a IOL on the crystalline lens. So that is called as a phakic IOL, or we can exchange the crystalline lens with the help of the artificial lens to correct the refractive error. So these are the 2 pictures of phakic IOL in which the natural crystalline lens is not removed. On the top of that, the lenses have been implanted. The picture on the left side is iris clip IOL. On the right side, the lens is injected in the sulcus. And another option is the removal of the natural lens and putting artificial lens to correct the refractive error. That's what we call as a refractive lens exchange. With the age, our lens gets opaque. That is what we call as a cataract. But then refractive lens exchange is a procedure. Even if there is no cataract, we can remove that clear lens and put a proper power intraocular lens to correct the refractive error. So this is the last slide, last video, 1 minute, 30 seconds video. So this is a video of a cataract surgery, or essentially a refractive lens surgery, in which essentially we remove the anterior capsule with the help of cystitome in a circular fashion. That is what we call as a capsulorhexis. After doing the capsulorhexis, the nucleus and the cortical matter which is inside the capsular bag is loosened with the help of jet of fluid, so that the nucleus gets loosened and it can be rotated freely inside the capsular bag to manipulate during phacosurgery. Now, after that, we actually insert a pen-like probe that is called as a phaco handpiece with a tip, and then we divide the nucleus into smaller pieces with the help of ultrasonic phacoemulsification and the aspiration. So then vacuum is applied, the piece is grasped, and then it is chopped, and this small piece which has been chopped, which is free now, is then aspirated with the help of phaco. So that is what phaco is, and after that we remove the soft cortical matter and then we put an intraocular lens. So this is an intraocular lens. So I think I have finished. It's almost 12 minutes. Thank you so very much. I hope it was a very simple talk and you understood it nicely. Okay. Thank you so very much. Thank you, Vikram, again. I will stop the sharing now.
Thank you. Thank you so much for such an enlightening talk. That was indeed an informative talk for us. Now I welcome our next speaker for today's CME, a well-known dermatologist practicing in Amravati, Dr. Yogesh Jhanwar, sir, and he will be speaking on demystifying dermatological problems in day-to-day practices. So I request Dr. Jhanwar, sir, to please start your session.
Sorry, Dr. Jawar, sir, we cannot hear you, sir. Hello, Dr. Jawar, sir. Hello. No, sir, we cannot hear you, sir.
अनम्यूट करता हूँ.
Yes, sir, we can hear you now.
अभी आवाज आ रहा है?
Yes, sir, we can hear you now.
अच्छा, यहाँ पे वॉल्यूम बढ़ा सकेगा कुछ? Okay, good afternoon, dear friends. Thank you, Vikram and team of Vikram for giving me opportunity for my talk. My talk will be on some common skin condition I will be taking, and how the newer treatment modality has changed the outcome of treatment in skin diseases. This is what my talk will be. So Vikram, my voice is clear. Okay.
Yes, sir, your voice is clear. You can continue, sir.
Okay, so I'm sharing this screen.
Sir, you can see the share and screen at the bottom, sir.
Yes, share.
Green color. At the bottom, you can see the share screen option, sir.
Yes.
Next to chat.
क्या मेरा स्क्रीन शेयर हो रहा है?
Screen is shareable, sir. Just you need to on the slideshow, sir, by pressing the F5. Yeah, it is available, sir. Now you can start, sir.
Okay, so here I start with my first case, a very common condition. A 15-year-old male came with a complaint of well-defined silvery white scaly patches all over the body. Almost 75% of the body is involved. The condition is very easy to diagnose. It's a case of psoriasis vulgaris, right? It's a case of psoriasis vulgaris. We know this is a very chronic condition, although it is a non-infectious, but it creates a lot of psychological problem. The child will find it very difficult to go to the school and play with the other kids. So this is what the treatment, like a newer treatment, like a cyclosporine we have given to the patient, and there is a good resolution in the psoriasis patches. The another view of the same psoriasis, frontal view. So what is a guideline for management of psoriasis? We have a earlier treatment like methotrexate and a coal tar and a PUA therapy. But nowadays many newer therapies are there like acetatin, cyclosporine and biologics, which has changed the outcome of a psoriasis condition. Here the 2 injection of the biologics will give you the remission for many years also. So this kind of newer modalities has changed the outcome of the psoriasis. This patient was given a cyclosporine 2.5 to 5 milligram per kg body weight is given like it's. I will straightway move to the next case. The case is of Stevens-Johnson syndrome. Earlier, this kind of cases we used to treat with a immunoglobulin and a lot of high dose of steroid. But nowadays, if we prefer cyclosporine drug here, there is a very rapid resolution in the patches. You can see the very rapid result. More than a week time it takes. So role of cyclosporin is like it faster recovery, rapid revitalization. It reduces the hospital stay, also reduces the mortality and morbidity. You can see the kid having a faster resolution and a faster revitalization. So case of Stevens-Johnson syndrome, we no longer use the steroid here and we prefer cyclosporin, the newer drug option. My third case is again a female with around like 33 years of age, having a crusted lesion on the face, scalp, all over the body. She is a widow. She was not able to do the work because of this lesion, and her condition was diagnosed after the histopathology as a pemphigus foliaceus. Earlier, the treatment for pemphigus was a steroid, and we know the side effect of steroid when given in a very high dose, which is required for the pemphigus. It gives rise to a lot of side effects like bone marrow, weakening of the bones, Cushingite syndrome, hypertension, diabetes, acid peptic disease. But now with this newer drug like rituximab, which is a biologics, which is to be given in a 2 doses on day 1 and day 15, we can see the very nice resolution of the lesions, and the patient is off the treatment since last 3 years. So this is a rituximab, which is nothing but a biologics, which we use for the pemphigus now. So the treatment has changed of pemphigus from steroids and immunoglobulins to the biologics. Here we are having a better result and lesser side effects. Another case of a pemphigus before and after, another case of pemphigus before and after. Next case is a fungal infection. The case I have chosen this here is because nowadays, earlier we used to get a fungal infection restricted to the groin area. But nowadays what we are getting the fungal infection. So the kind of fungal infection which we are getting is even after the treatment, they are not responding. That is called recalcitrant. They are becoming chronic, means they are taking more than 6 month duration. And even after the treatment, what we are getting is a recurrence back. So what has changed here? They are difficult to treat. They are involving the wider area of the body. They are not classical. They are ill-defined. Facial involvement was not common earlier, which is very common nowadays. Pediatric population used to get involvement of the fungus very less, but now it is very common. The duration of treatment used to be of 3 to 4 weeks. Nowadays it is more than 3 months. So this is what the things are changing. And the drug which are available, like all the drugs, after giving the recommended doses, patient keep getting the recurrence. The duration of the treatment has increased and the doses are almost double of all the antifungal. So the point to be noted here, the common condition, it is very difficult to be treated. Please avoid treating this patient with a low dose of antifungal and avoid using the steroid cream along with it, and treatment of all the family member is very important. My next case is again a common condition which we face nowadays is that people coming with lot of side effects of steroid cream which has been applied on the face, and this steroid cream they applied for the fairness purpose. This has been advised to them by either parlor or chemist or by some family physician for some pigmentation, for pimples and for some spots. But after initial improvement, what they start getting is a lot of disfiguring of the face, lot of pustular acne lesions. So the aim of presenting this, including this case, was to educate all the people. Like it's even if there is some condition where we need to use a steroid on the face, we should be very careful that the steroid potency should be very mild, even if we are using it, and we should try to avoid steroid combination antifungal cream on the face. The common side effect which we get is atrophy, erythema, telangiectasia, purpura, and lot of side effect. Here we can see like the skin looks very aging, telangiectasia all over the face. You can see the thinning of the skin and increase in the hair growth. You can see the before and after photograph after the treatment once the patient is improved. So the message is to avoid the steroid misuse. And the next case is like a hair fall case. What we do nowadays, apart from the traditional minoxidil therapy and finasteride, there are a lot many good options we have nowadays. You can see the result here in this case, this is over a period of like 4 to 5 months. This what we do is a platelet-rich plasma therapy, which we use for the hair growth therapy. So why platelet is been given? Because platelet has a lot of granules, alpha granules, which contain a lot of growth factor, which when we give to the area where we are giving it the, suppose we are giving it to the scalp, areas which are going through the like a catagen phase get converted into the anagen phase and the growth start again. So it's a very simple procedure. We also use this for the wound healing purpose. The non-healing ulcer, when we put a PRP over this or platelet, ulcer which is not getting healed since many months get very much faster resolution in a few weeks time. So it's another utility of the platelet-rich plasma therapy and a platelet-rich fibrin. So another treatment modality for the hair growth is a eye growth therapy, or you can say laser light therapy for the hair loss. You can see these patients like it having a thinning of hair, they gradually started improving the density. And this is what we use the hair growth, which is nothing but a diode laser for the growth of the hairs. So this is also known as the red light therapy and cold laser therapy. It's a non-invasive, painless, without any side effect, and it's irritate the photon into the scalp tissue and which absorbed by the weak cell, and that in turn give rise to the encouragement of the hair growth. My next case is about the acne. The traditional treatment for and clindamycin as a erythromycin in a topical form. But nowadays our main treatment line we prefer. In fact, most of the cases we don't need any antibiotics. The better drug is isotretinoin. We have like it, we act on all the controlling the sebum, act as antibacterials, and it's a wonderful drug which has changed the treatment the way we used to do the treatment earlier. And laser added to the more better and a faster resolution, faster outcome we get, lesser antibiotic required. So there is a less chances of antibiotic resistance because azithromycin is the commonly used drug, which is again required for typical mycobacterial infection and many respiratory infection. To avoid those kind of things. This is the laser modality is done for the acne, and this laser has help in a rapid resolution, and the scarring can be corrected with this lasers. Another alopecia areata. This female came with this. Since last 5 years, she is of having a hair loss, and you can see the good regrowth of the hair. So earlier, what we used to give is the intralesional steroid hairs and like immunosuppressive drug like azathioprine and a methotrexate and apremilast. But nowadays, what we have is a tofacitinib, which is a JAK inhibitor. Although it has been approved for rheumatoid arthritis, but it has been found to be a very good in a alopecia areata and vitiligo also. The next case is a case of a herpes zoster with a lot of scarring and a hyperpigmentation. You can see the very nice resolution over here. Almost pigment is gone and the scarring is also minimized. Next case is a another case is a scarring on the nose, resolving almost equally. So this is a laser which has been used for the scar. Here the burn case which is almost resolved after the single session of the dermal nevus resolve. So this is about the newer treatment option. We have like a fractional CO2 laser, which is a wonderful modality nowadays in our like ornaments like it. We can treat a lot of scarring with this, stretch marks. It is used for the anti-aging and cosmetic purpose as well. And my last, not the last, the next case is a case of a vitiligo, very classically diagnosed milky white patches on the face. The previous treatment used to be like a PUVA therapy where we have to give a surrealin and expose the patient to the sunlight. But now with the help of like a targeted phototherapy and exam and laser, the same thing like it we have the results has become very nice enough. We can get in a few months time a rapid repigmentation in case of a vitiligo, as is seen in this case like here. This is how the targeted phototherapy we give. The same treatment is also used in a chronic eczema and psoriasis. The lesion which otherwise we find it very difficult, they keep going for years and years, which can be resolved with this eczema or targeted laser. You can see the response in a 5 months time. My last case is a case of a young female having a pigmentation on the face. You can see both the side of the face, there is a good amount of hyperpigmentation and a thickening of the skin. the treatment which we have done, and this is what the result with this, and this is for what we use for this is like a Q switch laser, Q switch ND-arc laser, along with some multivitamin supplements and sun protective creams. And this is a very useful very useful tool used for the all kind of hyperpigmentation like birth nevus, melasma, freckles. And very popularly, we use it for the laser facial during the marriages, and it is also been used for the tattoo removals. I think the time permitted me, and I was able to finish it with the times. So thank you very much. Thank you very much, all of you. Over to Vikram.
Thank you very much, sir. That was indeed a fast revision of all the common dermatological conditions, I must say. Thank you, sir.
Okay, thank you.
Now I would like to invite our next speaker for today, a very versatile personality, I must say, Dr. Anuradha Tote ma'am. Ma'am has done her DOMS and DNB ophthalmology. She was a winner of a very prestigious Ishwar Chandra Award in DOMS. She also have done MBA and also currently pursuing a degree in psychology. Ma'am is an international JCI trainer and a well-known motivational speaker. Ma'am is an author of a book titled What We Missed in the Medical School. Ma'am is also a beautiful Kathak dancer and also winner of a TV dance show, Dum Dum Adam. So a very versatile personality, I must say. Welcome, ma'am, on your next topic, that is healthy relationship. Over to you, ma'am.
Thank you so much. Thank you, Dr. Vikram Wankhede, sir, for a wonderful introduction. It made me feel so special. Am I audible to everyone? Just show me a thumb or give me some indication that I'm audible.
Yes, ma'am, you're audible, ma'am.
Okay. Thank you so much. And first and foremost, of course, I would like to thank the ADC, Dr. Vikram Deshmukh, sir, our president, Dr. Rohankar, sir, and the whole team for giving me this wonderful opportunity. And I have a very good topic today, very interesting and very important for everybody in the professional aspect as well as the personal aspect. It's very important to have healthy relationships. So I think I'll share my screen now. If it's possible, let's do it. Otherwise, we'll do without it also. Okay, I think you can see the screen.
Yes, ma'am, screen is visible, ma'am.
Okay. So yes, and please, Dr. Vikram Wankhede, please remind me when 1 minute is left so that I can wind up, right?
Ma'am, you can take your time, ma'am. Don't worry.
It will go on like anything. So it's better that you remind me, okay?
Yes, ma'am, of course. Thank you.
Okay. Yeah, thank you. Well, a very good topic, and that is healthy relationships. See, it so happened that I went to a friend's house, and there was a beautiful plant there. It had many flowers, beautiful flowers, and the fragrance was great. And after a couple of days, says after 8-10 days, I had to visit her again. So I went again to her house, and what I saw was that plant was dying. And the flowers were all drab and the color was not there and the fragrance was not there. It was stinging. I just asked her that, "Aap isko pani kyun nahi dalte ho?" So she said, "Kya fark padta hai?" Fark padta hai. अगर आप किसी प्लांट को पानी नहीं देते हो, उसको सनलाइट में नहीं रखते हो, तो उसकी ग्रोथ नहीं होगी, वो जिंदा नहीं रह पाएंगे. Similar is with our relationships. Relationships are like these plants. Let us first understand the concept of relationship. The very concept of relationship is, first and foremost thing is, they are alive. Please remember, they are alive, they are living, and whatever is living is dynamic. It changes. So it changes and it also can die. सिर्फ मरती नहीं है relationship, कभी कभी सड़ जाती है. So we have to be very, very careful. We have to nurture relationships. Relationship को पानी देना और sunlight देना और खाद डालना, all that is very, very important. Otherwise, that relationship will no longer be there. So please remember the concept of relationship. It is alive and it is dynamic. Why do I say it is dynamic? It is dynamic. It is ever changing. Let me tell you that I was I had a very good friend, a best friend, I should say, in my school days, like 6, 7. And then we did not meet after that. After 8th standard, I did not meet her. And it so happened that for post-graduation, I went to Mumbai and there I met her. And her house was just across the road of our hospital. So when I was so thrilled about it, I was so excited that I'm going to meet her again. And I went to her house. She was okay, like she was very welcoming, but still I couldn't feel the warmth in her. I had met her after, say, 10, 15 years, and she was only paying attention to her kid. She was busy feeding her kid. Relationships change. Let us remember that. And this I understood only when I had a kid, that feeding the kid is so very important to a mother. So let us understand that relationships change, people change, and let us accept the change. So 2 things we have to remember: relationships are alive and they keep on changing. You have to nurture them, and then only you can have a very good relationship with anyone on this planet, right? Now, the second question which comes to our mind is, are relationships really important? Now, let me tell you, a Harvard study, which is supposed to be the longest study, it is like 79 years long study, and Robert Ballinger is the director. Now he's the director, he's the 4th director for the study, and they have, they have taken this up since long, and 724 participants are there, and since 79 years they are doing it. So they have come to a conclusion in his talk, a TED talk which went viral in 2015. He said that I can boldly say and clearly say that good relationships, people with good relationships can have a healthier and happier life. So it is very, very important for us to have a very good relationship, right? So we go on to the next slide and let us see the importance of having good relationships. One is, of course, a healthy and happy life. Some very important points are also like someone on your side always. You'll always have someone on your side. The feel-good factor will be there. Mental support is always there. You'll get help whenever needed, and your self-esteem will increase, which is very, very important for your self-confidence. And stress will decrease to a great extent. Then it keeps diseases at bay. It contributes to your success. Yes, definitely it does. Now, in that very study, he had also mentioned that it delays aging. If you have good relationships with a lot of people, healthy relationships with people, you are social, you're talking to people, and you love to interact with people, and you're happy, good relationships if you have, it delays aging, and it also declines the rate in which your memory, memory goes down. So it boosts your memory in a sense. And of course, it is the reason to be happy. So now there are many, many things about relationship. It is a huge topic, but I would just like to give you 5 pearls if I can in these 10 minutes. So let us see. The first and foremost, what I would like to tell you is, if you want to have a good relationship with anybody on this earth, you have to trust that person. Trust is very essential. Let me tell you what I can recollect about it is that there was a small girl, and she went with her father. She was crossing a bridge, and there was a huge storm. There was a strong wind blowing. So this girl was holding the finger of her father, and then she got afraid, and she said to her father that, "Father, please hold my finger. You hold my finger." So father asked, "But you are holding my finger, right?" She said, "No, you hold my finger." That father asked, "Why?" You know what she had to say? She said that, "Father, I trust you more than myself." If you have that kind of trust in anybody, I think your relationship is going to go a long, long way. So you have to believe in that person completely. You have to believe that that person is going to be with you in your thick and thin. And then definitely that relationship will go a long way. Second thing, of course, we all know is communication. म्हणतात ना की सुसंवाद असावा, पण सुसंवाद असण्यासाठी संवाद तरी साधा. संवादच साधत नाही आपण, तर सुसंवाद कुठून येईल? And why are we not able to do this? It's not just about children, it is about adults also. That what happens to us is we are so much stuck with our gadgets. We are so much into the internet world, into the web world, into the virtual world, that we are entangled into it, and we just cannot come out of it and be in the real world and communicate with the people. If you come out, see, you have your work to do, but 86400 seconds we have every day for everyone. So this you have to utilize in a wonderful way. If you want to communicate, you can really communicate with people. You have to rather communicate with people. And if you want to have good relationships, you have to give quality time to quality people in your life. See, if your mother is sick, you have to be there at that time with her. If your father is running through a financial crisis, you have to be there with that at that time with him. If your brother has lost a cricket match, you have to be there at that time with him. Your friend has lost her mother, you have to be there at that time with her. Then only you will have a good relationship with her. So time factor is very important in relationships also. And we have, I mean, it is very, very essential that we come out of the virtual world. You need a digital detox. It's very, very essential. So what I would suggest is just half an hour in the morning and half an hour in the evening is more than enough to use the gadgets. Otherwise, what Einstein has said, we all know that he has said that it is not long when a day will come when technology will surpass human interactions, and there will be a generation of idiots. And here we are, I should say. We know the physical and the mental and all the side effects of these digital devices, but still we are entangled into it. So let us come out of the virtual world and be in the real world, and then only we can communicate with people. And that is very, very important, to have good and healthy relationships with people. Unconditional love. This is an essential factor, very, very essential factor, at least in a family, I would say. Unconditional love. Do not expect anything. Let me explain it to you. There were two brothers, Kartikeya and Krishna. Kartikeya was in the 3rd standard and Krishna was in the 1st standard. And this Kartikeya happened to have thalassemia, and it was a very poor family. Every time they had to take Kartikeya to have a blood transfusion, and they used to take him to the government hospital. Now, it so happened that in the government hospital, the blood was not available. Now, Krishna, who was in the 1st standard, had the same blood group. So the parents said to Krishna, Krishna, beta, we are not getting blood anywhere. Will you please donate blood to your brother? So this Krishna, you know what he said? He said that, okay, I will think about it till evening, and then I will tell you. So, at evening, he told his mother that, okay, you can take my blood. And then they took the two brothers to the hospital, and they had the blood transfusion and all. And after the blood transfusion, the small Krishna, he came running to his mother, and he was so happy. And you know what he had to say? He said that, Mama, I am alive. Imagine. That child who thought that when I give my blood to my brother, I will be dead. Still he gave blood to his brother. This is what I call as unconditional love. If you have this unconditional love in you for the members of your family, for your close friends, your relatives, definitely you'll have a very, very, very strong bond with them. And it gives a different kind of happiness to yourself also. So unconditional love is a very important factor into it. Yes. Now, another very important point we want to cover here is, look at the spectrum. This is a bar, which you can see. It is a spectrum of white and black color. Actually, to the right side, to my right side, the bar is black. Imagine it to be black if you can't see that. So here are people who are very ugly looking, and they are not good in academics. Professionally, they are not doing well. They are not good at the family level as well. So all fronts, they are not good. Okay. And on the other side, it's a wide spectrum. Now, in the wide spectrum, you have people who are very good looking, they are very good academicians, they are very good at dancing, they are very good at sports, they have all the good qualities in the world. So my question to you is, where do you plot yourself on the above spectrum? Yes. I think some people will answer it right. Some may feel they are into the black zone, or some may feel they are into the white zone. But the answer is, most of us, rather I would say all of us, fall into the gray zone. And if you are gray, why don't you accept others to be gray? We are full of imperfections. Why don't we accept people with all their imperfections? We need to accept a person completely. When you accept a person completely, then only you can understand that person better and you can treat that person better. It helps you to deal with that person better only and only if you accept the person completely. If you have a wife who is very good looking, it will definitely be there that she will be very dominating as well. So you have to accept her completely with her dominating nature and blah, blah, blah things. So once you do that, I think it will be easy for you to understand her and have a good relationship with her, for anybody for that matter, right? So it's very important to accept the person completely. Forgiveness is also definitely a very, very important point, but it is, let me tell you, it is not so easy to forgive anybody. Okay, leave apart forgiveness. It's a word in great depth, and it's a very spiritual thing to do, and we must do it, but then it'll take a lot of time, a lot of spiritual knowledge to do it. But at this stage, let us at least let go. At least let go. See, just don't mind if people hurt you. At least try to understand in what situation they are, what are they thinking, what are they going through, and that is why they have hurt me. Okay, fine, let go. I'll just continue with my life. It's okay. At least do that so that you don't spoil your relationships with people. Now, the one very important thing which comes in between when we try to have good relationships with people is something called as ego. Right? We can discuss it in detail later on, but just a few things about ego. I'm going to just demonstrate it to you. Now, in this slide, you can see the Earth, right? Look at the Earth. The Earth is so big compared to the Mars, Mercury, and Pluto. Now look at the Earth. What happened is, now the Earth is so small as compared to the Uranus, Neptune, Jupiter, and Saturn. And now look at the Earth. It's just a small dot as compared to the Sun, right? And now look at the Earth. It is just a small dot. That arrow is showing the dot. And look at the Sun. It is so small as compared to the Sirius, Pollux, and Arcturus. Okay. And now let us look at this picture. Now you can see that small dot, which is the Sun, which is shown by the arrow. And look that the dot is so small as compared to the Antares. And Antares is the 15th biggest star in the sky. It is not the first biggest one. So when the Sun is so small, how small will the Earth be? And when the Earth is so small, how small will the world be? When the world is so small, how small will India be? And when India is so small, how small will Maharashtra be? And when Maharashtra is so small, how small will Vidarbha be? And when Vidarbha is so small, how small Amravati will be? And when Amravati is so small, how small are you and me? We are just small, very tiny creatures, a small speck of dust. Anybody can just blow us out. Why do we have big egos? Let us shed off the big ego. And once we do this, I think it is very easy to have a good relationship with people, because the distance between us and people decreases when we have a small ego. We are so comfortable with anybody and everybody, and actually anybody and everybody are equal in the world of God, right? And the very important thing which I want to tell you here is, All these things will happen only and only when you are happy with yourself. So you have to accept yourself completely, accept the situation in which you are completely, and love yourself. Really be happy with yourself. And when you are happy with yourself, you will radiate happiness, and then only people will come to you and you'll have good relationships. If you are not happy, see, whatever you have, you can give it to people. And if I have frustration, I have negativities, I have disappointments, I'll give those to the people. But if I have happiness, I have love, I have joy, I have compassion, I will give all that to the people, and then I will have very good relationships with them. So it's very important that you have very good relationship with your own self, and then only you can have good relationships with people. And we will have just a quick recap. First, what we saw is the concept of relationship, that it is living, it's alive, and it is dynamic. It has to be nurtured. The importance of a good relationship is definitely you'll have a healthier and happier life. Trust is very important. The 5 pearls which I have given you is trust, unconditional love, communication, accepting the other person completely, forgiving, if not forgiving, at least let go, and have a very good relationship with yourself. And to wind up, let me give you a secret to live long, like to be immortal, I should say. So that secret is मौत से बचने का एक शानदार तरीका है. मौत से बचने का एक शानदार तरीका है लोगों के दिलों में जिंदा रहना सीख. ये कफन, ये जनाजा, ये मौत सब बातें हैं मेरे दोस्त, वरना इंसान मर तो तब जाता है जब उसे याद करने वाला कोई ना हो. So friends, be kings and queens of hearts and live in the hearts of people. All the very best, and thank you so much.
Thank you so much, ma'am, for such a cheerful talk. I must say, the wonderful message you have got us: love yourself to love others. Thank you, ma'am. Now, I would like to invite our next speaker of today's CME, Dr. Neeraj Raghani, sir. He is a renowned cardiologist and the director of Zenith Hospital, Amravati. He will be talking on changing trends in the cardiology. So I welcome Dr. Raghani, sir.
Am I visible?
Yes, sir.
Am I visible and audible, Vikram?
Yes, sir.
Thank you
yes,
very
sir,
much.
You can go ahead, sir.
I thank IMA, Amravati, and both the Vikrams, Vikram Wankhede and Vikram Deshmukh, for giving me this opportunity. Good evening, everyone. Very nice lecture we had today. Nice lecture by Anuradha ma'am and the previous speakers. So my lecture is on the role of interventional cardiology in current medical practice. As we are progressing and making advances in the technology, and in our cities like Amravati, we are getting new things day by day. So I thought, let's keep a topic where we can touch on things where what we are doing in day-to-day practice in cardiology. So interventional cardiology is a procedure where we do a minimal invasive procedure with targeted instruments to treat the diseases of the blood vessels mostly. But in cath lab, we do other invasive procedures by other people like interventional radiologists to treat diseases of even the bones, the GI systems, and the brain also. But my topic will remain limited to the procedures related to the blood vessels. So what are the advantages of these interventional cardiology or radiology procedures? That they are very minimal invasive. They does not need any general anesthesia, no large incisions. They are generally outdoor basis patients. Then we discharge on the same day. The minimal pain, minimal blood loss, and less expensive and less recovery time. So there are some non-vascular interventions which can be done in catheterization laboratory that we have, but I'm not going to deal with them today. So generally we start from the heart, that is the bread and butter, and 99% of our work deals with the cardiac procedures. Though we do other vascular procedure also, but the most common procedure we do day-to-day basis is our coronary angiography and coronary angioplasty. So it's a small, simple procedure which gives us the data and picture of coronary arteries, and if there is any significant blockages in the coronary arteries, we do deal with them with different methods to relieve the blockages and to increase the blood supply to the myocardium so that the patient's angina and dyspnea can be relieved. So like this in picture you can see there is a lesion in the left anterior descending coronary artery which is been balloon dilated, and after balloon dilatation and stent deployment we can see the stent has been compressed or released and the blood flow has been increased. So similarly, like coronary, we can do peripheral intervention where in this patient we can see a very diseased and atheromatous popliteal artery with a very tight stenosis just at the knee joint. And these kind of vessels, they don't need stent, but just balloon dilatation. And now today we do have drug-coated balloons or drug-eluting balloons which are coated with the drugs like paclitaxel or sirolimus or everolimus, and they release the drug so that the atheroma does not regrow again. So these are some advances. This is an example done at our hospital, and we have dilated this femoral artery by a drug-coated balloon. And after dilatation with the balloon, we can see there is a dilatation of the femoral artery and there is a relief of the limb ischemia. So from blood vessels, we will come to the cardiac shunt. So what we do in day-to-day practice for cardiac shunts like atrial septal defect or ventricular septal defect or patent ductus arteriosus, we can minimal invasively close these defects by putting devices. We can see here a ASD, atrial septal defect, and by putting a umbrella shaped device which is compressed and inside a tube which we call as sheet, and when we push the device, we open the left atrial disc and then pull it across the septum, across the defect, and release the right atrial side of the disc, and then we check the position on echo and release the device there, and slowly over a period of 6 months these devices get endothelized and there is a closure of the defect. So we can similarly we can close the ventricular septal defect and even the patent ductus arteriosus, and they are quite easy to do, very less invasive. Even I have done PDA closure in around 2.5 to 3 months old child, and it hardly takes time. Maybe I think 15 to 20 minutes, maximum half an hour is required after the child is under anesthesia effect to close the defect. So similarly, like closing the defect, another thing which we can do in current cardiology practice is doing balloon dilatation of the walls. In mitral stenosis or aortic stenosis, we can dilate the valvular stenosis by balloon. And now latest technologies are available where we can implant wall over the balloon and dilate and implant the wall across the defective wall. So it is called as transcutaneous aortic wall replacement, TAVR, TAVR. So this is the latest therapy available in the world for severe aortic stenosis, especially in high-risk patients, those who cannot go for open heart surgery for valvular aortic stenosis. So from wall, we will come down to the electrical problems of the heart, like complete heart block, for which we can do a pacemaker implantation and relieve the complete heart block of the patient. Similarly, for aneurysms of aorta or aneurysms of great vessels, we can put a covered graft. Recently, I think in January or last December, we have done in one patient at our hospital who was having a large thoracic aortic aneurysm, and we have put a covered graft. And this covered graft, what they do, they exclude the aneurysm from the blood flow, and slowly they get compressed and shrunken, and the risk of rupture of aneurysm reduces. So this is also very easy procedure which does not require large incisions, or initially when grafts were not available for aneurysm, there was a big vascular surgery required, and it's a very high risk surgery. We can open other vessels like renal arteries. Here you can see the renal arteries completely compressed in the first lesion, and we can put a stent into the renal artery and open the renal arteries. We can do embolization of masses in the body to control the bleeding. If there is any vascular lesion like fibroids, uterine fibroids, or tumor where we suspect high bleeding risk in liver or kidney, we can do embolization, selective embolization of that lesion, tumor, or hemangiomas. And sometimes they automatically, after getting necros, it's a treatment itself. And sometimes the mass gets shrunken and the surgeon then operates with a minimal bleeding. So that is another thing which we can do by doing in cath lab. Embolization is a material which causes necrosis of the tissue, and what we use generally, we use PVA particles or gel foams or coils to occlude the vessels. The PVA particles are very minute microscopic particles which go and block the capillaries of the AV malformations or the capillaries of the tumor or the growth. And by blocking the capillaries, it causes the necrosis of that area. If the tumor is having a large single vessel which is supplying that area, we can occlude that vessel by putting a coil there. So coil acts by blocking the vessel, while the PVA particle or gel foams acts by blocking the capillaries. So here are some examples like this is a spleen. This is a patient of epistaxis, severe epistaxis, where we have closed the artery of the nose by putting up a coil here. And these are some examples of renal and splenic trauma where the patient was bleeding like anything, and we have closed the splenic vessels or renal artery to stop the bleeding. This is one case which we have done at our hospital. She was a patient of mitral valve replacement, and I was having severe menorrhagia. And for surgery, the patient's warfarin we could not stop because the patient was having mechanical mitral valve. So this patient was treated with PVA particle embolization, and she was having large fibroids, and her bleeding stopped on the second day of embolization, and her size of fibroid also reduced. And after stabilization, after hemoglobin build up and blood transfusion and stabilization, we got her operated also by managing the anticoagulants of that patient electively. But in emergency, we control the bleeding by PV embolization. So this is very effective and very nice therapy to control the bleeding from fibroids in a high-risk patient where the hysterectomy could not be done immediately, or patient is bleeding like anything and we have to stop the bleeding. Embolization can be done for renal, for varicocele, for pelvic embolization post trauma, or sometime where there is GI bleed and the gastroenterologist could not control the bleeding by endoscopy or colonoscopy. We can go into the splanchnic vessels or into the mesenteric arteries and can cause necrosis of that area and can stop the bleeding for life-saving emergencies. Another emergency is bronchial artery embolization. Generally, it happens, the hemoptysis occurs in patient with post-tubercular patient, where the patient is having large cavities and one of the blood vessels open into the lung cavity and patient coughs out blood. And there is if there is a significant amount of bleeding occurring, significant amount of hemoptysis occurring, and it is not getting suppressed by drugs or other medications, we need to take the patient into the cath lab and do a super selective injections into the bronchial arteries, and if we can see any malformations there, which are the bleeders, we do inject coils or PVA particles or sponge to stop the bleeding. Sometimes in malignancies where the mass is big and there is a metastasis and the patient is on chemo or radiotherapy, and the surgeons want to reduce the size of the mass, we can do chemoembolization of that masses, which acts by reducing the blood supply as well as by delivering the chemotherapy to that site. And it is generally used by gastroenterologist or interventional radiologist, especially in the liver cancers. because liver is having dual blood supply from the portal vein as well as the hepatic vein, hepatic artery. So if we inject by hepatic artery or portal vein, the neck rather than necrosis, it generally causes more of chemotherapy related effect. So this was all about the putting up the devices inside the blood vessels and opening up the vessels and doing what we can do. Sometimes when we cannot deal with things and there are a lot of thrombosis and patient comes with acute ischemia, any limb ischemia or organ ischemia, we can super selectively go into that vessel and do thrombolysis also, and we can dissolve the clot and establish the blood supply. Recently we had one patient who was post GI surgery, and the intestine was a part of intestine was removed because of ischemic necrosis of that intestine. He again came with second episode of GI ischemia, the intestinal ischemia, and the surgeon said if we remove the remaining part of intestine, it will be very difficult for the patient to survive. So in that patient, we did intravascular thrombolysis, and post thrombolysis, his symptoms improved, and we could save his intestine, and the patient is doing good. Nowadays, we are at Amravati also, we are doing a lot of venous procedures, especially in patient of, I am doing a lot of patient with deep vein thrombosis, where we are doing thrombus extraction from the veins, we are doing thrombolysis inside the veins, and we are doing dilatation and with balloon and stent of the venous stenosis to improve the venous outflow from the limbs. And we do also here laser therapy for varicose vein. So these are all vascular intervention in the veins which we can do. Another important thing which we can do in cardiology or interventional radiology is the removal of the foreign bodies from the blood vessels. Sometimes we get calls that while putting up the sheets or devices or while putting up a dialysis catheter, the wire we left inside or wire went inside the blood vessel and we are not able to remove. So we can go from another side, snare the foreign devices. We can hold up the foreign devices and remove them outside. So there are a few other things that I will not go into details, but what is new that is happening in interventional cardiology, now we are having intravascular ultrasound that we can see inside the blood vessels, what is happening inside the blood vessels, how is the blockages, how is the atheroma, whether the atheroma is having a thin cap, it is an ulcerated plaque, it is a high risk plaque, whether it is having high chances of rupture, whether it is a calcified blockages, what kind of therapy it needs. If the block is very much calcified, we cannot open it by just doing a balloon or putting up a stent. We need to shave the calcification by doing either laser atherectomy or diamond burr ablation, that is called as rota ablation. So intravascular ultrasound is very advanced imaging for the blood vessels. Second new thing which is coming up now is the fractional flow reserve, and this FFR or fractional flow reserve tells us whether any blockage of the heart or coronary artery needs any therapy or not. That means if your patient comes with 70-80% blockages, but the symptoms are not very typical, or the patient is having atypical symptoms like atypical chest pain and it does not fit into the blockage, whether that blockage is causing that symptom, we can decide by measuring the pressure across the lesion, across the blockage. So if there is more than 20% pressure drop across the lesion, that means there is a significant ischemia caused by that blockage and we need to deal with that. So rather than going with the anatomy or percentage of blockage, whether it is 40%, 50%, 80% or 90%, we do rely more on physiology, that is a drop of pressure across the lesion. And if there is significant drop of pressure across the lesion, we do need to deal with that lesion irrespective of the anatomy of the lesion. So this is very good thing where even where the patient is having multiple lesions, like patient is having 4-5 lesions of 70-80%, and we don't know whether we should send that patient for CAPG, or there may not be, there may be only one lesion, one blockage which is causing problem, and we can deal with that lesion by just putting up a simple stent and not sending that patient for bypass surgery. Newer therapy are rota ablation, where we are going to ablate or burn or debulk the calcium of the blockages to give a better results with angioplasty to expand that lesion properly so that the long-term results should be good. Patient should not come with re-stenosis or repeat blockages in that area. So we need to remove the calcium from the region by doing rotablation. We can do laser atherectomy by burning with the laser of that calcium and opening up the vessel. So in our hospital at Amravati, we do have a very good cath lab, and we are doing a lot of complex procedures, including peripheral procedures. And to help us, we have equipment like intravascular ultrasound, FFR, rotablation with us. And in most of the cases, what we are doing femoral, while removing the sheath, we do transcutaneous closure of the puncture site of the blood vessel or the artery without giving compression, so that patient should be comfortable and patient should not develop any hematoma. So these are the latest advanced therapies which we can do, and slowly we are bringing them to our city like Amravati. And I think I keep just this topic to get a brief awareness of what we can do in interventional cardiology or in cardiac catheterization laboratory. Thank you very much.
Thank you very much, sir, for a wonderful talk. Now, going ahead, I would like to request Dr. Ashish Sabu, sir, to be our next speaker for today. We know that beloved Secretary of IMA Amravati, Dr. Sabu, sir, he also is a professor and head of the Department of Psychiatry at PDMC. Sir has many publications in national and international journals. Sir has hold many posts in psychiatry associations and Lions Club also, apart from IMA. Apart from the academician, he is a very well-known chess and table tennis player. Also have an interest in bridge as well as basketball playing. And we all are really aware of his passion for music, and really classic knowledge of his Indian cinema is really known to everyone. So without any further delay, I would like to welcome Dr. Ashish Sabu, sir, on the topic of stress management in the medical practitioners. Sir, over to you.
Thank you, Vikram. Now I will start immediately with the screen sharing. Now, I'm audible?
Yes, sir. You're audible, sir.
Yeah. Can you see the screen?
Yes, sir.
Okay. So my topic for So my topic is stress in medical practitioners. Now, overview of my lecture is I will be talking about stress, the definition, pathophysiology, complications, and management of stress, and especially pertaining to our medical practitioners. So what is stress? Stress is the body's reactions to any change that requires an adjustment or response. Stress is a state of mind produced by demands or tasks to be performed, and it is produced due to differences between the demand and capacity. Now, there are two types of stress, eustress and distress. Eustress is the one which actually with the persons is helpful to the persons to improve the performance. Because if that thing is there, then the persons won't get much of the problems and will able to do the work properly. But distress, when the task becomes too much beyond the capacity, then the state of exhaustion of resources occurs, then it leads to distress, and which is the one which causes the harmful effects on the body. Now, the stressor is any factor that demands attention, energy, action, performance, adjustment, and coping. This may be in the form of physical demand, environmental situations, social conditions, and it can be internal or external. Now, what is the pathophysiology of the stress? Initially, whenever the person is stressed, he gets the physiological responses occur. That is, an increase in sympathomimetic activity and increase in adrenocorticoid activity in the body. And there is a psychological responses. which is mostly in the form of a fight response and flight response. Now, the physical symptoms of stress includes, immediate symptoms includes increase in heart rate, blood pressure, switching, dilatation of pupils, increase in respiratory, bowel movements, muscle tension, increase in sugar level, gastric juice secretion, and long term it results in exhaustion and fatigue. While psychological symptoms, the immediate symptoms are anxiety, hypervigilance, impaired concentration, the person starts speaking rapidly, impulsivity, anger, nervousness, indecisiveness. While long term, the person may land up in depression, may stop going to the work, may go involved in the alcohol or other drug abuse or dependence, and there is overall decline in the performance of that individual. Now, what are the complications of stress? Now, there are many physical illnesses which can be related to the stress, like peptic ulcer disease, diabetes, hypertension, different types of heart disease, various skin disorders, even rheumatoid arthritis can be precipitated, and there is susceptibility to infections due to the low immunity. And the psychiatric illnesses like depression, anxiety disorders, substance use disorders can also. Now, what is the vulnerability of the stress? Who gets stressed easily? So there are genetic factors are there and developmental factors are there, which we cannot alter or there. So we'll focus mainly on the other things. That is, the one is working environment. Now, for doctors or for medical practitioners, the working environment is very important. And here we have to deal directly with the patient. The patient is the one which direct one-to-one contact we face with the patients. There are different types of patients. There's a lot of diversity there, gender-wise, age-wise, linguistic, religion, educational, urban, rural divide, occupational, etc. etc. There are so many different types of patients we see in our day-to-day practice. And then we have to also deal with our staff. There is a different number of staff. Sometimes they are not absent, they are not present, they are not coming, or they're irregular, they are not performing, doing the work properly, they are not communicating with doctors or patients or properly. So their work competence is not there. Sometimes there is a problem with their sincerity and obedience. And the infrastructure where we are working, the setup which we are working in, it may be an hospital setup or a clinic setup, and how much comfortable it is, or what are the facilities available over there. So these are all the things which are mainly affecting the working environment. The other thing is professional competence. Now, the doctors of various belonging to various categories, they have different types of qualifications, like graduations, post graduations. They may have taken some kind of a crash course or some certifications, etc. Their professional trainings, how much skill they have developed, about the skills about evaluation, diagnosis, management, what is their level of knowledge, and their most importantly communication skills. It is also very important aspect in the competence, where the person has to be, the communication has to be very clear, proper, worded, emphatic, and graceful. Otherwise, that can cause stress to the patient. And now, specialty specifics. We are like IMA is a group of different types of different faculties. We are seeing just now different types of faculties are presenting different types of presentations. So there are different types of practitioners also. So general practitioners, which are the usually primary healthcare providers, they have got their routine emergency situations, and they have to maintain the proper referrals or investigation. Oh, sorry. And then there are physicians who have got the OPD as well as indoor management. They have to manage, refer patients. They have to refer the patient sometimes to even some super specialties, different specialties, and they have assessment of seriousness. And there is so their hierarchy, their work is more complicated. The surgeons, of course, they have got the different types of tasks they have to perform, the operative, non-operative, operative skills, where to avoid and what kind of things, and how sometimes we are supposed to operate or sometimes we have to avoid it. and the emergency situations or emergency services they have to provide. And some specialists, super specialists also, they have got this, they have to use their knowledge and skills, as well as there are some paraclinicians who have to work skills, handling of the staffs, as well as technical issues are maybe involved. So, and we have to, one more aspect we have to deal is the medical legal issues. So medical legal issues, there has to be proper assessment, notifications, dealing with police and other authorities, or proper certifications, record keeping, and there are negligence which has to be avoided, and the communication which has to be very proper, risk assessment, informing, taken proper consent, or handling the mobs and nuisance, which is a major problems nowadays. And we have to also keep the records properly, which are maybe OPD or indoor records, or of sheets, treatment, procedures, investigations, and certification is also important. Whenever we are maybe giving the certificates about fitness, unfit, disability, death, etc. Now the social status. Now these are about the professional. Apart from professional, we know that doctors is a respected medical practice, is a respected profession, and it has got some kind of a status in the society, and their lifestyle is also very different. It's not like just like any other people. You cannot are not supposed to. You have to maintain certain kinds of your living styles, your eating habits, your dressing sense. Okay, and whatever the tools of comfort you may be using, okay, employing the servants, having big bungalows, vehicles, modern facilities, etc. This is the kind of style usually we tend to maintain. And there are some kinds of habits which some of us may have got or may have been deal with, like smoking or consumptions of liquor, gambling, betting, etc. And in leisure activities, we go for parties or some expensive tours or travel, etc. And that is also associated with our financial aspects. The revenue sources is primarily we earn from our profession, and other sources are maybe like job, business, investment in different things which we will do. All these things, the finance, whenever the money matter comes, we have to have deal with whatever the stress associated with that. And expenditure which we may do for our profession, as well as to maintain our status, commitments, family needs, all our hobbies and habits. Now, all these things may lead to stress. So what exactly is, how do we manage this stress? There are two major methods which we do it. Pharmacological means, which is the drugs, and non-pharmacological means, which I will be dealing later. So drugs, basically the objectives are usually to control the symptoms, to prevent the long-term effects, and to prevent complications. The medications which may be used commonly are mostly they are antidepressant drugs or anti-anxiety drugs. Sometimes even anti-hypertensive drugs like propranolol and other things may be used. And sometimes we do use sedative hypnotics to just control the purpose is just to maintain the symptoms. It doesn't actually relieve you from the stress, but so what are the non-pharmacological methods? These are important. Like one is the lifestyle change. Personal growth, we know that we have to grow personally and other things to have, we have to become more assertive. Earning name and fame through appropriate means. That usually can help us to keep our stress-free life, keep ourselves stress-free. The reprioritization of goals. The goals must be smart. We have to prioritize them, and we have to learn to say no to whatever the things we are not capable of, or we are not other things. Smart means it has to be specific, it has to be manageable, it has to be affordable, it is reasonable, and it is target oriented. And there has to be increase in feeling of self-esteem, self-efficacy. It is the achieving. Sometimes we can go by doing the small things together, not try to do many things at one time, but do it one by one or other. Strengthening of our social network. This is also important. We have to keep in touch with our friends, family, communicating, visiting friends, going out, or just relaxing ourselves. Even this. So that can help us to keep us our stress level down. Day-to-day adjustment sometimes we have to do. We need to be ready for change, be prepared for changes. Changes is the thing which is going to be there, and we have to adjust ourselves accordingly. And we have one important aspect we have to keep is the time management. If we do everything on time, so if your routine schedules, if they are fixed, we keep it on time, so it keeps our stress level very low. And but we should not be very rigid about it. We should be a little bit flexible and keeping whatever the times where we keep sufficient time allowed for our planned activity. Work management, we have to work as per our capacity, as per the capacity of, even if we are delegating the work, we have to do it with looking at the capacity of the persons to whom the work is being delegated, and taking breaks in between and learn how to relax. These are some important things while doing the work. Otherwise, this work can add to our stress. If we are helpful to other people, like from friends, family, and community, that always helps you relax. Even like I'm involved in kind of a social activity, social gathering, and just helping the people to others, helping others, just gives me a kind of relaxation. I feel more relief from the stress. Exercise is very important. Physical exercise that persons can go in gym, walking, cycling, gardening, stretching at least 30 minutes twice a week is good enough, and other things can be a good relaxing exercise. Yoga, meditations can be done to calm yourself and keep the stress level low. The diet is very important. Different type of color foods like fruits, vegetables, they have got a lot of antioxidants properties. So they prevent the cellular damage, degeneration, cancers, and they also help us to relieve the stress. So in non-vegetarian foods, the fish as well as white meat is good for relieving the stress. In vegetarians, the whole grain cereals, fresh spices, herbs, fibers can help. We have to avoid certain things like caffeine, sugar, fats, or processed foods, which can add to our stress level. And for water, it is better to use a filtered water rather than bottled water. The sleeping habits are also very important. We have to keep a fixed time, more or less. It's not that sometimes we are getting up, sleeping late, or sometimes we are getting up early. If you usually maintain a proper time for sleep, it is good. And exercise or no, there should not be any exercise must be done in the day. It's not good that you should walk in the night. There should not be any exercise 3 hours prior to our sleep. It can add to our stress level. You should, and many of the times we should avoid the daytime naps. The sleep has to be more in the night sleep. The rooms should, if they are dark, silent, and peaceful, it gives a good sleep. The color of the rooms should be light. No stimulants, tea, coffee, nicotine, or liquor 3 hours prior. And there should be a gap of 2 hours between the dinner and sleep. Sometimes, many of the times, the people just take the dinner and go to sleep. So it is not advisable. And some pleasurable activities within an hour of the sleep can be done. No emotional disturbances before sleep is advisable. The habits and hobbies. The leisure activities like reading, watching TV, and movies can help in relieving the stress. One should laugh very freely and loudly. There must be some time for fun. The humor also helps in reducing the stress. No alcohol and other drugs for these things, because it can give rise to, alcohol can give rise to temporary sedations or relaxation, but it causes rebound effect of increasing stress. The creativity can be used in the form of drawing, painting, music, cooking can help you, and dancing and sports can always help in relieving that stress. So that's all from I hope I have been able to finish my talk in 10 minutes and without exceeding much of the time. Thank you, Vikrams, both the Vikrams, for giving me the opportunity. Thank you.
Thank you, sir. Thank you very much, Dr. Sabu, sir. Now, I would like to invite our next speaker today, Dr. Naresh Tarde, sir. We all know that he is a pediatric, he is practicing in pediatric genetics. He is a fellowship, he has done his fellowship in clinical genetics from the Gangaram Institute of Medical Sciences. and he is also a president of Sickle Cell Society of Amravati. Sir is also a lecturer in the Department of Pediatrics, PDMMC, Amravati. So he will be talking on sickle cell disease, a misdiagnosis. I welcome Dr. Taide, sir. Over to you, sir.
Yeah, thanks, Dr. Vikram. If I'm audible? Hello.
Sir, your voice is a little bit cracking, sir.
Okay. Is it okay now?
Yes, sir. Better.
Is it okay now? Yeah.
Better, sir.
So, okay. So I am talking about the sickle cell disease, which is, as we all know, the common problem in our region. And so background, it is a sickle cell disease is one of the most common hemoglobinopathy, not only in India, but also in world. Very common in our region and most of state in 1 minute, please. Video is not there. Excuse me, Vikram, video is not there.
Sir, we can hear your video also.
Very common in our region.
Hello.
If you are you able to see video.
Hello. Yes, sir.
Hello, Vikram. If video is there, my video is there.
No, sir. We are not able to see the video.
Oh. Okay. So what's the problem? Okay, no problem. So it is very common in our region of the state in India. It is commonly considered a problem of only SC and ST community, but I want to tell that it can be seen in every community. It has very varied presentation, and so many times diagnosis may be delayed. Can present first time at any age. So age criteria doesn't rule out sickle cell disease. It is more than what we read in our book. So be prepared. Sickle cell disease can be present in any way to you. Prevention is the best way of cure. And recently some new medication are arrived, and we can treat very well with the sickle cell disease patient with this medicine. Bone marrow transplant and gene therapy is the curative treatment. So in this, as actor can present with the various roles, similarly sickle cell can present to you with any kind of manifestation, which can be seen in our further cases. So this is the case one. It is a 9-year-old male child admitted with history of fever since 8 days. This is a recent case admitted in our Punjab Rao Deshmukh Medical College with history of fever 8 days, abdominal pain since 3 days, vomiting way and altered behavior since 5 hours. On examination, child has pannus hepatosplenomegaly with GCS of 9/15. Suspecting acute failure with hepatic encephalopathy, we have done some investigation. Investigation show hemoglobin of 5.4 with PLC count of 65,800 with polymorphic predominance and platelet of 42,000. We rule out dengue and HIV, HBsAg, SCV was negative. HIV and HEV was not possible because the kit was not available at that time in our hospital. Liver function test was grossly deranged with SGOT and SGPT both 4,000s, and bilirubin was 16.62. And in spite of treatment of hepatic encephalopathy and conservative management, a patient was survived and succumbed to illness after 3rd day. So after his death, the reports of electrophoresis also arrived and show that patient is suffering from sickle cell disease. So sickle cell disease as hepatopathy and hepatic encephalopathy can be seen. And till now, I have seen 3 patients which are present with severe encephalopathy, hepatic encephalopathy-like presentation, out of which 2 are survived, and this patient was not able to survive. This is the case 2, which is a 23-year-old male roaming around to many doctors for severe back pain, and some orthopedician advise him for MRI spine, and the MRI radiologist done the MRI spine and give the diagnosis on that MRI that it is the possibility of sickle cell disease in this patient. And when he came to me with this report, he doesn't have any splenomegaly, mild anemia is there, and his HB electrophoresis show that he had a sickle cell disease. So sickle cell disease can be done by sometimes radiologist also, if we don't keep the different presentation in our mind. Case 3, this is a 6-month-old infant, came with history of recurrent fever and joint swelling and irritability. On examination, he had pallor, hepatosplenomegaly, and investigation show that he is suffering from sickle cell disease. So we can see sickle cell disease can present at any age. This child is a 6-month-old, and for previous case, the person is of 23 years old. This is a fourth case. A 4-year-old female child came with history of abdominal distension and vomiting. UHG suggestive of subacute intestinal obstruction. So patient goes to surgeon, and as there is no active surgical management, patient was admitted in our hospital. And on examination, she had pallor, splenomegaly, and we came to diagnosis of sickle cell disease with mesenteric ischemia in this patient. So it is a form of vaso-occlusive crisis and can present as a subacute intestinal obstruction in sickle cell disease. This is case 5, a 27-year-old female with history of 3 recurrent abortion. During this pregnancy, she was evaluated for anemia, and this time she was diagnosed as a sickle cell disease. In her history, there is no past history of icterus, blood transfusion, or bone pain. So she diagnosed first time at 27 years with only history of recurrent abortion as a sickle cell disease. So you can see the clinical features at diagnosis. At diagnosis means when this patient was diagnosed as a sickle cell disease first time. So this is data of 180 patients in our Amravati district, where we can see common features like anemia, fever, recurrent VOC, pain, icterus. All these symptoms can be present in the patient, but they can also have some unusual features which we have to keep in mind. With this, they can go to first time, may go to the surgeon, may go to physician, or may go to some orthopedician, or may go to the eye specialist, or sometimes see a neurologist also. These are the subacute intestinal obstruction, hepatic encephalopathy like presentation, may have just loose motion or constipation like presentation with subacute. Then they may have stroke, severe respiratory distress, non-healing ulcer, and sometimes the child may come with near death, or patient may be brought as a death patient also. So age at the time of diagnosis, in this chart we can see the 10% of patient, approximately 10% of patient diagnosed at below 10 years, below 1 year as a sickle cell disease, while similarly 10% or more than 10% patient diagnosed after 20 years as a first time as a sickle cell disease. So age is not a criteria to rule out the sickle cell disease. In this, my study, the adult, as I am a pediatrician, adult percentage may be low, but we know that sickle cell can present at adulthood also as a first time as a sickle cell disease. So most of us think that in sickle cell disease, there is a hepatosplenotomy by 5 years of age. And if the spleen is present, that rules out our diagnosis of sickle cell disease. But we have also seen that in less than 5 years, approximately more than 50% have a splenomegaly. But surprisingly, after 5 years also, 50% of patients may have the splenomegaly still present in them. So presence of splenomegaly doesn't rule out sickle cell disease, especially in our Indian patients. So something about treatment. So whenever the patient with sickle cell disease came to us, we think that it is the fluid, and fluid is the main treatment for the sickle cell disease. But remember one thing, don't overhydrate the patient, maintain U volume. Then we afraid about the painkiller. We give painkiller as a SOS basis, but don't afraid of painkiller. Give round the clock painkiller. Use special pain scale or different pain scale to know what is the severity of pain in this patient. Managing pain of the patient is very important in sickle cell or any disease patient. As per NABH criteria, that pain scale is in our protocol, admission protocol in the NABH criteria. So don't afraid of painkiller. Give round the clock painkiller in patient with sickle cell disease. Then start hydroxyurea if there are the indication for starting it. Don't transfuse routinely. Whenever the patient with sickle cell disease come to us, if he has a VOC, if his hemoglobin is 8, we transfuse that patient, but it is not required. So with patient with sickle cell disease, we have managed with hemoglobin of 5 and 6 without transfusion if they doesn't have fit for the indication for transfusion. So value of hemoglobin is not a criteria to transfuse sickle cell patient. It is based on the what is their symptoms, how he presented, and what is the indication for giving the transfusion. Then they can have pregnancy and they can give birth to the child. So don't tell them that they cannot have pregnancy or pregnancy may not be possible in them. And if we treat them properly or they take care of themselves properly, then they can have also a long life. So we have to counsel the patient that sickle cell disease doesn't mean that patient will not survive beyond 30 years or 40 years. He can have a long life also. Newer therapy, they are the L-glutamine, which is FDA approved in July 2017, which is almost after 20 years of hydroxyurea. Hydroxyurea was approved for sickle cell disease in 1997, but after 20 years, we get L-glutamine approved for the sickle cell disease for treatment in more than 5 years of age. But my personal experience show that L-glutamine in our Indian patient increase the vaso-occlusive crisis. So I am not very much happy with this drug. Then second drugs recently approved, but not at present not available in India is voxelotor, which is FDA approved in July 2019. And another drug which is now just December 2019 approved was the crisanolol, which is given once a month therapy and is shown to have some very good effect in the patient with the sickle cell disease. So these are the new therapy in the sickle cell disease. There my talk never end without telling about the prevention, because in this type of genetic disorder, as we all know, prevention is better than the cure, and we should always try to prevent this disease whenever you diagnose any patient with sickle cell disease with trait, whether he is trait or disease, you have to try to counsel the patient and the family for prevention of this disease. So I check every patient by HPLC, which is required to be done only once in his lifetime. Then I have also tested myself for hemoglobinopathy, and I request everyone who is attending this lecture and everyone that check yourself, your children's, your patient for this hemoglobinopathy, which is easily preventable if we diagnose them in time. If we know that we are trait and we avoid marriage with the trait, then we avoid the birth of deceased child. So our aim is lest there would be no child born with sickle cell disease by 2025 in Amravati and by 2050 in all Maharashtra. Thank you. Thank you very much.
Thank you, Dr. Paide, sir. Our next speaker for today is Dr. Pankaj Ghundial, sir. He is a practicing radiologist in Amravati. He's practicing last more than 20 years. He's the director of Ghundial Radio Diagnostic Center. Dr. Ghundial is a national faculty for MSB IRIA and IRIA conferences. He is a past vice president of Vidarbha Radiology Association and past joint secretary of IMA, past president of Lions Club also. We are all well aware of his passion for fitness as well as sports. So over to you, Dr. Pankaj sir. The topic for Dr. Pankaj sir today is imaging of tumor mimics in brain.
I kindly request Pankaj sir to please unmute.
Yeah.
Okay.
Yeah, share. Is it seen? Hello.
Yes, sir. We can see the slide, sir.
Okay. Good evening, dear friends. Today I am speaking on imaging of tumor mimics in brain. Case number 1, 20-year-old lady presented with sudden onset of diplopia with gas palsy since 15 days with history of mild ataxia. In this, we are seeing a abnormal signal in the pons. Entire pons is involved. There is no expansion of the pons and there is no enhancement. So no significant expansion, almost entire pons involved, no enhancement. This is a classical pontine demyelination. Follow-up scan after the treatment shows significant reduction of the hyperintense signal seen in the pons. Comparison case, in this similar normal signal is seen in the pons, but it is eccentric in position and there is an expansion of the cord, and on contrast, there is some enhancement seen. So expansion of pons, eccentric in position and enhancement goes more in favor of pontine glioma. Case number 2, 16-year-old girl, acute onset of excessive sleepiness, of psychiatric, non-signaling hyperintense signals are seen just adjacent to the third ventricle in the region of hypothalamus. On coronal, it is very nicely seen again. The lesions are seen in the hypothalamus. Post contrast shows poor enhancement. So treated with IV methylprednisolone for 3 days followed by oral steroid, there is significant improvement in all the symptoms. So this was a classical hypothalamic demyelination. Now, number 3, low-grade fever, URTI since 5 days with history of convulsions. Abnormal signals seen in the both cerebral hemispheres, which are hyperintense on T2, hypointense on T1, and on contrast study, open ring-like enhancement, and the incomplete portion of the ring is seen on the gray matter side of the lesion. There was no mass effect, no surrounding vasogenic edema, and on diffusion weighted images, there was mildly increased ADC. So the MR spectroscopy, there was elevation of choline and elevation of lactate. So this was classical tumefactive demyelination. Case number 4, 17-year-old boy presented with altered sensorium and convulsions. Abnormal signals seen in the bifrontal region. Hyperintense on T2, hypointense on T1, and on combination of contrast, there is an intense enhancement seen along the falls. So this was classical history of beta cell lymphoma, induction therapy, and history of convulsions. MRI shows an isointense signal on T1 and flare, and patchy or punctate hyperintensity on T2. Post-contrast, MRI shows irregular ring-like enhancement. On diffusion-weighted images and ADC, the wall as well as the nodular soft tissue display diffusion restriction, while the content don't show the restriction. And single voxel MR spectroscopy over enhancing area demonstrates diminished N-acetyl aspartate to creatinine ratio, normal choline to NNA ratio, and normal choline to creatinine ratio. So this was classical fungal abscess. Patient had developed febrile neutropenia, neutrophil count 0, similar lesions were in lungs, chest, liver, and spleen. Succumbed to it, postmortem confirmed the findings. 20-year-old boy studying in 3rd year of college presented with left-sided hemiparesis, lower limb more than upper limb. Abnormal signal is seen in the right frontal region with extensive surrounding vasogenic edema, and on administration of the contrast, There was an thick-walled ring-like enhancement was seen. This was reported as lymphoma oblique tuberculoma outside, and it was followed by an post-op shows again a lesion which was thick-walled, but in this we were seeing internal isointense lesion. So this was classical aspergilloma. Aspergilloma abscess appears radiologically identical to the other brain abscesses as classical ring-enhancing lesion with striking high signal intensity on diffusion-weighted images. Aspergillus abscess may have peripheral low signal intensity on T2. This is very well appreciated on GRE or SWI images. 50-year-old man presented with fever since 5 days and left hemiparesis. Abnormal lesion is seen in the right parietal region, and mild hyperintense rim was on T1, dark T2 rim due to free radicals, and there was diffusion restriction, and on contrast peripheral enhancement was seen, and lactate peak was seen on MR spectroscopy. So this was classical pyogenic abscess. 40-year-old man presented with altered sensorium and right hemiplegia. Abnormal signals seen in the both the cerebral hemisphere. Multiple lesions were there with surrounding vasogenic edema. Largest was in the left basal ganglia. And on MR spectroscopy, there was a reduced NA and mildly increased choline and lactate peak. So this was classical toxoplasmosis. Patient was HIV positive. Then case number 9, 59-year-old man or male on the operated case of GBM, received radiotherapy, presented with multiple episodes of seizures and 6 nerve palsy. Abnormal signals seen in the left occipital region, hyperintense on T2, hypo on T1. And this was an expansile lesion in the white matter extending up to the cortex with classical Swiss cheese pattern of the interior arcuate fiber. Half perfusion shows low cerebral blood volume. So this was classical radiation necrosis. 45-year-old male patient came with sudden onset right lower limb weakness. Abnormal signals seen in the left frontal region on CT scan. On FLAIR also abnormal signal was seen on this left frontal region, and angiography was normal. DSA was also normal. Then we have done a MR GRE sequence. A GRE sequence is a very, very important sequence in which we are seeing a hemorrhage. And there is a blooming seen in this region. So blooming was on T1, pre and post contrast. There was a punctate-like contrast enhancement was seen, and some enhancement was seen. So this was classical cavernous angio. These are a collection of sinusoidal vascular spaces, clotted, unclotted blood in various stages of oxidation. On MR, typical cavernomas looks like raspberry or popcorn-like appearance, and gradient echo sequence shows this lesion better than T1 and T2. These are the multiple sites of the cavernomas. Then 35-year-old lady presented with headache, occasional tingling in all the limbs, vertigo on and off, abnormal signals seen in the pons. On SWI and GRE, the lesion was very nicely. So this was a capillary telangiectasis in brain. These lesions are most often solitary, but sometimes it may be multiple. Common location, pons, cerebellum, or spinal cord. T2 and FLAIR shows normal or slightly increased signal, and T2 shows ISO or low signal. But T1 contrast MRI shows stippled enhancement. If large, can show branching and linear draining veins. Then this is a case which presented with holocranial headache on and off since 3 years, 3 episodes of TIA in last 1 year, weakness of left upper and lower limb with slurring of speech. On examination, conscious, oriented, no focal neurological deficit. Abnormal signal seen in the left temporal region. On CT scan, abnormal lesion seen. On administration of the contrast, there was a ring-like enhancement was seen, but intensely enhancing lesion was inside that ring. So we suddenly decided that this is some thrombosed aneurysm. In same sitting, we have done a CT angiography. In this, very nicely it is seen the lesion is along the middle cerebral artery. So this was classical partly thrombosed right MCA aneurysm. It was confirmed on DSA. Then last case, 25-year-old transplant recipient on triple immunosuppression, presented with left hemiparesis and diplopia. Abnormal is in the test, and there was some enhancement was also seen, and diffusion restriction was also there. And on plain MRI study, a hyperintense sinuses were seen. So this MR was a dural sinus thrombosis. This was a classical venous infarct. Thank you.
Thank you, Dr. Gundial, sir. Now, I would like to welcome our last speaker for today, our dashing ADC, Dr. Vikram Deshmukh, sir. He is a practicing urologist and andrologist at Sri Urology Center, Amravati. He is practicing here since 2013, and we know that he is a pretty good singer. So today he'll be talking on the management of prostate cancer. So over to you, Dr. Vikram, sir.
Thank you, Vikram. Okay, am I audible?
Yes, sir, you are audible, sir.
Yes, sir.
Okay, I'm sharing my screen.
Sir, at the bottom, you can see a green symbol.
Yes, I've done it.
Okay.
Can you see my screen?
Yes, sir.
Okay, so good evening, everybody. Today I'll be speaking on the management of prostate cancer. This is just an overview so that people should understand the basics of prostate cancer. I'm not going too much in detail. So this is the 5th most common cancer worldwide and the 2nd most common cancer in men. Now, as you can see in this picture, the highest incidence in the world is seen in North America, where we have about 250 cases per 1 lakh. And the lowest incidence is seen in Asia, where the incidence is only about 2 cases per 1 lakh. Now, over the last few decades, there has been a shift to a more favorable stage at presentation, which is accounted by PSA screening. Now, though this is true for the Western world, whether this is true for India and Asia is something which I have a doubt. This is the reason is because majority of the patients that we diagnose in India are still diagnosed in an advanced stage. So when we say that we have a low incidence, it actually may be a result of inadequate screening. Now, this is a disease of old age and majority of the patients are diagnosed after the age of 65. And with increasing age, there is a proportional increase in the incidence. Majority of these cancers are sporadic, 15 to 20% are familial or hereditary. Now, familial or hereditary cancers are diagnosed in early age and they are caused by mutations in the cancer-related genes. Now, the etiology of sporadic cancers is not known. However, there are some facts which are clearly established. So what are these facts? One is that prostate cancer is androgen dependent. Androgens are important in development and maintenance of the prostate gland, and exposure to androgen is a prerequisite for prostate cancer to occur in later life. Maintenance of prostate cancer is also dependent on androgens, and this is the reason why androgen deprivation treatment is used in the treatment of advanced prostate malignancies. Estrogen is considered to be protective, and this is the reason why it is used in metastatic prostate cancers. Other factors which confer an increased risk are chronic inflammation of the prostate, leptin, etc. Now, as you all know, adenocarcinoma is the most common pathological type. Majority of the tumor mass is located in the periphery of the gland, and it is multifocal in 85% of the patients. Most common site of metastasis are lymph nodes and bones. Now, presentation is variable. Some patients are identified by screening, while some patients may present with lower urinary tract symptoms. Advanced cases may present with obstructive uropathy and metastasis. Now, for screening, we have to use both the digital rectal examination and serum PSA because detection rates are higher when both are used together than any single test alone. Digital rectal examination alone will miss a substantial proportion of the cancers. Now, who are the candidates for screening? These are men between 50 to 75 years. Above 75 years, we should screen only if we have a clinical suspicion of prostate cancer. Now, on digital rectal examination, any nodule, induration, or asymmetry in the prostate should arouse the suspicion of CA prostate. Now, serum PSA is a other important test which we use for screening, and a normal value of serum PSA is considered to be less than 4 nanogram per ml. Now, this should not be used as an absolute cutoff because serum PSA is influenced by many factors. For example, there is an age-related rise in serum PSA of about 0.04% per year. Hence, a patient between the age of 60 to 70 years, for him, a PSA of up to 6.2 nanogram will be considered as normal for his age. PSA is also affected by the gland size of the prostate. This is because PSA is a normal secretory product of the prostate gland, and benign prostatic tissue also secretes PSA. In fact, cancerous tissue secretes less PSA, but we get a higher value in the serum of PSA in cancer because of the distortion in the cellular architecture in cancer leads to leak of the PSA into the blood. And this is the reason why we get a higher value in the serum in cancer. But the benign prostatic tissue is also secreting the PSA. So if we want to find out what is a normal PSA value for a particular gland size, we have to multiply the gland size by 0.15, which is the PSA density. And if the level is higher than this value, then only we should suspect prostate cancer. For example, if the patient is having a 60-gram prostate, a PSA of up to 9 nanogram per ml will be normal for this gland size. Now, there are other factors which can affect PSA. For example, any prostatic disease like prostatitis, CA prostate, benign prostatic hyperplasia can also lead to rise in PSA. We must understand that PSA is organ specific, not cancer specific. It will rise in any disease of the prostate. It is also seen that when patients have acute retention of urine, which is caused by prostatic infection, PSA may be on the higher side. Any instrumentation of the lower urinary tract, for example, perurethral catheterization, prostatic biopsy, TURP, all these may lead to a rise in PSA. So if we have any patient in whom there is a if he has any of these factors which can lead to a rise in PSA, there is a recommended waiting period where we should do the PSA. For example, if the patient has undergone a catheterization, we have to wait for 7 days before we do a PSA. If he has a acute urinary retention, we have to wait for 3 weeks. If he has undergone a prostatic biopsy, 4 weeks. We must understand that even if we get a higher value of PSA, we have to wait for this recommended period. We have to repeat a PSA, and then only if we have a suspicion, then we should investigate further. Now, 5-alpha reductase inhibitors like finasteride and dutasteride also reduce PSA by 50% at 6 months. So we have to do a baseline PSA before starting these drugs. Now, whenever we have a suspicion of CA prostate, and this has to be confirmed by a TRUS-guided prostate biopsy. TRUS is transrectal ultrasound-guided biopsy. This will confirm our diagnosis by histopathological examination, and a minimum 12-core biopsy is recommended. Now, somebody may ask, why should we do TRUS? Why not do a finger-guided biopsy? Because availability of TRUS is a problem. It is not available in all cities. Somebody may also ask, why should we do a 12-core biopsy? Why not do the 6-core biopsy? Some majority of the people in remote centers are still carrying on with finger-guided biopsy, so they may take 6 cores, 8 cores. So why 12 cores? So first I will answer why TRUS. So whenever we do prostatic biopsy, the whole of the prostate has to be systematically biopsied so that we do not miss any part of the prostate. Again, if you have a suspicious lesion identified on TRUS, it has to be targeted specifically. So this is possible only with image guidance. Why 12 cores? Is because a 12-core biopsy will have the maximum cancer detection rate of 30%. We know this by clinical trials. If we take less number of cores, the cancer detection rate decreases. If we take more number of cores, then the cancer detection rate remains the same, but the morbidity of the procedure increases. Now, the TRUS-guided biopsy will give us the lesions grading, which is important in deciding further management. Now, I won't go into the staging because this is theoretical. Now, we must understand that for staging, we need the information from digital examination, serum PSA value, and the imaging studies. We must understand that imaging studies have their limitations. Extraprostatic spread is something which is not very accurately seen on imaging studies. So we have to use other methods to find out the staging. I'll come to that later. So once we have the investigations done, then we can divide the patients into 3 categories. One is organ confined CA prostate, second is locally advanced CA prostate, and third is metastatic CA prostate. Now we must know that CA prostate is a slowly growing cancer, and average doubling time is about 2 to 4 years. And if we want to give curative treatment to the patients, the cancers have to be identified in early stage, that is organ confined stage. Once the patient is having locally advanced or metastatic prostate cancer, we can only offer palliative treatment. Now, if the patient is identified early by screening, and if the cancer is found to be organ confined, and the treatment options are radical prostatectomy, radiation therapy, and active surveillance. Now, radical prostatectomy is considered as the gold standard treatment for organ confined tumors because it offers the possibility of cure. It is more effective in achieving long-term progression-free survival. It provides accurate staging. Treatment failure is readily identified, and mortality is rare. Now, for the patient to undergo radical prostatectomy, he should have a good life expectancy, and the tumor must be biologically significant and completely resectable. And obviously, the patient has to be medically fit to undergo the surgery. Second treatment is radiation therapy. Now, the outcomes of radiation therapy are reported to be comparable to those of radical prostatectomy. However, evaluation of the outcome is more complicated. Biochemical endpoint used to determine treatment success is controversial. Now, why am I saying this is because when we give radiation therapy, the outcome is assessed either by serum PSA or by doing prostatic biopsies. This is how we would find whether the patient is having a recurrence or not. Now, the problem with serum PSA estimation while the patient is undergoing radiation is that the PSA will fluctuate because of the radiation effect. So it takes about 2 years to know whether our treatment has succeeded or not, because that is the time when the PSA value will be more accurate in predicting the recurrence. If we try to do the biopsy, then because of the radiation effect, interpretation of the biases is difficult. So it takes about 2 years to know whether we have succeeded the treatment or not. But from the clinical trials, we know that radiation treatment has almost similar outcomes. So to radical prostatectomy, so it can be offered to patients. Third option for organ-confined tumors is active surveillance. Now, by definition, this means that we are dealing the primary treatment if there is biochemical or histological progression, that is cancer progression, then only the primary treatment is given. Primary treatment is radiation therapy or radical prostatectomy. So why should we do active surveillance is because many prostate cancers are not very aggressive, and if the patient is having organ-confined tumors, if he has low life expectancy, if we have a well-differentiated tumor, if the core involvement is less. So if we overall find that the tumor is seen to be less aggressive in these patients, but we can try to avoid over-treating these patients, and we can put them on active surveillance. And we then intervene only if we find that the PSA is rising, or if clinically we are suspecting that there is a tumor progression. So for this, we need to do digital reflex examination, PSA 3 monthly and biopsy every year. So advantages, over treatment is avoided, and the definitive treatment is effective for majority of the patients with signs of progression. The disadvantage is that it increases the anxiety, and window of opportunity for cure may be missed, and attempts at nerve sparing surgery may also be missed. Now, second category is locally advanced tumors. Now, these are 10% of the newly diagnosed cases. Now, we must understand that many patients who are thought to have organ-confined CA prostate actually have locally advanced tumors. This is because the imaging modalities like CT, MRI have a limited role in identifying extra prostatic spread. So they may go wrong when you think that it is organ-confined tumor. It actually may be a locally advanced tumor. So any patient who is having a locally advanced tumor or organ-confined tumor, supposed to be an organ-confined tumor, they should undergo risk stratification. For example, a D-amico risk stratification is commonly used, where we use serum PSA value, Gleason score, and stage, and patients are then categorized into low, intermediate, and high risk. Now, risk here basically means risk of having an advanced tumor. So when we are or when we think that the patient has an organ-confined tumor, and if we do the risk stratification, and if he comes in high or intermediate risk, so he is basically not considered as a ideal candidate to be treated as an organ-confined tumor. He's taken as a candidate who is in all probabilities having a aggressive tumor, and in these patients we do not offer them definitive treatment like radical prostatectomy or radiation therapy, because they are most likely going to have biological relapse. So in these patients, we should use combined modality treatment. That is, if we are doing radiation therapy, we combine it with androgen deprivation treatment. That is, we give systemic treatment for us to avoid biochemical relapse. So coming to the third and last category, that is metastatic CA prostate. Now, this is a systemic disease. We can identify the the metastasis either by doing a PET scan, PSMA PET scan, or bone scans. And for these patients, we have to use systemic treatment. So first, what we do is we do androgen deprivation treatment, because as I've already told that all these prostate cancers are dependent on androgens. So we have to remove their primary source of spread. So androgen deprivation treatment is the basic treatment for systemic control of CA prostate. It basically means castration, which can either be surgical or chemical. Now, although androgen deprivation treatment is extremely effective initially, all of these patients eventually land up with a castrate-resistant prostate cancer. So approximately after 1 or 2 years, even if you have done a castration, the patient will start showing evidence of biochemical relapse. The PSA will start rising. And this is the reason why all patients of metastatic tumor have to be closely followed. They have to be put on surveillance. 3 monthly PSA clinical examination have to be done. And once we see that there is a biochemical relapse, then we have to put them on anti-androgens. Other treatments can also be given, like abiraterone acetate, and in late stages, or if the patient is having symptoms of metastasis, then chemotherapy is given. We have to understand that patients of CA prostate commonly have bone metastasis, and they may land up with complications of the spine. For example, cord compression is the most common and devastating complication, and it is an oncological emergency. In the initial stage, when if we give steroids, then the patients can they may not undergo any irreversible changes like cord ischemia. And in these patients, if we intervene early, we may avoid paraplegia and other disastrous complications. So any patient in whom we suspect cord compressions has to be put on steroids, an MRI of the spine has to be done, and androgen deprivation, that is castration, has to be done as early as possible. So this was just a brief overview of the prostate cancer. I hope that this information will be helpful for the delegates. Thank you.
Thank you, Dr. Vikram, sir. Now, we are coming to the final session of today's CME. That's a vote of thanks. We had a wonderful academic feast today, and let me remind you all that this feast will continue on tomorrow also. So don't go anywhere. Be joined with us for tomorrow's CME sessions also. I would like to thank our IMA Amravati President, Dr. Rohankar sir, and our Secretary, Dr. Ashish Sabu sir, for a beautifully arrangement of this annual day. The major role of annual day is, of course, our ADC, Dr. Vikram Deshmukh sir. So thank you, Deshmukh sir. I would like to thank all the executive committee members of IMA Amravati and all the speakers for today who have given their valuable time and given us a really good academic treat on the various topics that they have discussed with us today. I would like to thank all the delegates for attending the sessions in a large number and registration for the CME and to make the CME successful. I would also like to thank the technical team who is helping us in all this digital platform, because this is for the first time we are conducting our annual day CME on the digital platform, and really they helped us so much. So thank you very much for that. So see you all tomorrow with the 3:30. We'll start at sharp 3:30 p.m. tomorrow. Thank you.